Not that they weren't doing it too. I don't know. Okay, so alcohol, all these things, sadly. Tobacco, these are the problems, causes vasoconstriction. To which vessels in the body? All of them, including the placenta, which is why we get decreased blood flow, decreased oxygenation, and an adverse fetal size, meaning small. So, regular smokers, I mean, if you just smoke, when you get bored or go out, that's not a thing, but regular smokers, more than 5 cigarettes a day, they're likely to have a small or gestational stage baby, and they may have some of these problems as well. Will stopping during pregnancy decrease the complications?
Maybe.
If they stop early enough, they will. So some linkage, so says this article, and you can look at it later, but that smoking may lead to Tourette's in the infant, fetus, newborn. I'm amazed at how many people smoke during their pregnancy. I have some people in my own family, but it's like I told you, I'm from Kentucky, and these people live up there, and it's like if you don't smoke, you're not supporting your family. So these tobacco growers and stuff. Alcohol. Here's the big thing about alcohol. If we could restrict alcohol during pregnancy to 0, we would eliminate the #1 preventable, and that's a key word, preventable cause of central nervous system problems in children. Alcohol. It's the big offender. We're going to blame a lot of it on crack, crank, etc. It's alcohol that's causing the big CNS problems. Okay? And again, we don't know how much, when, etc. No safe level. Withdrawal for mom and baby. When does withdrawal usually start? Usually about 48 to 72 hours. Okay. What kind of symptoms might we see in a newborn who's withdrawing from alcohol? Irritable, gastrointestinal upset, so like vomiting, heavy spitting up, more than spitting up, and diarrhea, loose stools, tremors. In women or in adults, pregnant or not, what kind of symptoms do we see? Sweating, hypertension. The withdrawal from alcohol is the most serious physiologic, physical withdrawal of all substances. I tell you that because I don't want you to go home on the next holiday and lock Aunt Vi in a room and say, you're not getting any more until next Thursday. You're not coming out of that room. Because she's likely to have a hypertensive crisis, a seizure, a cardiovascular accident, and die. If she really is an addict, okay? An alcoholic. So if you're gonna, I don't have a problem with you locking the Aunt Vi up, but you might want to slip a little Valium or something under the door once in a while. Or maybe even 1 beer. Has anybody seen beer administered in the hospital as a medication? Sure. They'll put 1 beer, they always wrap it in aluminum foil or a little paper bag usually, so not everybody sees it. But will that keep them from having the DTs and all that? Yeah, it usually will, really. Okay. Or you might need to give them a, what do you call it? Tranquilizer, Valium, or Ativan, that's what I'm trying to think. A new Valium.
They're calmer, but you still say.
Well, they're still an addict, is that what you mean?
No, I'm saying like, they'll still feel like horrible.
Yeah, oh yeah, but they might not want to kill you.
Yeah, exactly.
Yeah. But you can give them a beer, you can give them an Ativan, and hopefully it'll keep them from having seizures and a heart attack and all that other stuff, and dying from it. So, and you can expect that about 48 hours after admission. On which patients? All of them. When you leave tonight at 7 o'clock and your patient came at 4:30 from the PACU, the sweetest little old lady you've ever seen. She's so polite. She has a lovely family. And you come back in 2 days, so Friday, and she is tied to the bed. 4-point restraints, and you're like, what happened? You're like, she went berserko last night. She was all over the place. Her blood pressure was high. Somebody might want to ask her how much she drinks every night. She might have more than 1 vodka beer, maybe. Or if they drink a 6-pack, you can usually make that 2.
I only have 1.
I only have 1 drink a day. Have you seen those memes on Facebook? 1 glass of wine and the wine glass is like this big. Okay, so here's the complications for the newborn. and this is fetal alcohol syndrome. There is something called fetal alcohol spectrum disorder, so it's sort of like autism. There's like a spectrum. So from not much problem, like we might not ever know, to wow, do we know. And the problem with these kids is, and with a lot of children who've been exposed to substances, is once they get over their initial withdrawal, you may not know they have problems until they get a little older. And so maybe they have speech and language delays, maybe they have behavior problems in school or learning problems. I did not drink during pregnancy for my kid who's dyslexic, I promise. But I'm just a dyslexic anyway. But you might not see those problems until later, especially with fetal alcohol syndrome, and they can be quite severe. It can be really bad behavior problems. And it's not something you can send them to counseling somewhere and they'll get over it. This is like a central nervous system damage kind of thing. Like they're not going to get over it. You're going to have to medicate them or lock them up or something. So this is kind of what they look like. They have a broad, kind of like Downs, but not exactly. Their ears are sometimes lower, their eyes are wide apart, and they have a broad space between their nose commonly. May have a thin upper lip, things like that. Sometimes you see kids that look like this and they are not fetal alcohol syndrome. They're what? Funny looking kids. They're just funny looking kids. They just don't know. We call those FLKs or FLBs, funny looking babies. So you got to look at their parents first. Sometimes they all look alike, like everybody in the family looks that way. But definitely can raise a red flag. Okay, marijuana, the most commonly used illicit drug in the United States, except for like the 4 or 5 states that legalize it. Now it's no longer illicit in their state. No reported teratogenic effect, but it does affect the sperm. So, not recommended if you're going to keep doing it. None of these drugs or substances are recommended to breastfeed if you're going to keep doing it. You know, I mean, don't let people, kid you. Sometimes they don't. Have you seen this thing on the billboard? It's been around for years. Metamorphosis, how they start out normal and they end up like this. Cachexic looking, their teeth are falling out because methamphetamines, cocaine, crank, all those are amphetamines, and so they suppress the need to eat, appetite, so they don't eat much, right? And it also, they're vasoconstrictors, so not only is it vasoconstricting the vessels around their heart and everywhere else, but in their gums as well, and so their teeth, after a period of time, their gums are unhealthy, their teeth literally start to fall out. So with that in mind, when you get a patient in triage, the other thing it does is it will cause preterm labor and abruptio placenta. So in the labor and delivery triage, when the mom comes in with little or no prenatal care, her teeth are falling out and she's in preterm labor and rule out abruptio, you might want to talk about getting a drug screen. Now, can we get the drug screen on the mom without her permission?
No.
No, you cannot. You have to tell her. It'd be nice if we could sneak around, right? But no, you really can't because then you have no therapeutic relationship. Can we get the drug screen on the infant without the mother's permission or knowledge?
Yes.
Yes, but you don't want to really, because then you have no relationship with her at all. And I'm not saying it's not easy. Sometimes, I mean, I've gone in rooms, I've seen this happen, where you go in the room to tell the mother what your suspicions are and what you're doing after you remove everyone else from the room, and you go in with a security guard, or the security guard stands outside the door, depending on how dangerous you think it is, because they might just take you down, okay? Because it's their baby and they don't want you doing anything to them. What you do have to have to get a drug screen on the baby is an order from a healthcare provider. And those are pretty easy to get. You call with a list of symptoms, they say, get a urine drug screen, and there you have it. But you don't want, you can do it in secret, but that's not the best way to do it. Cocaine is like the expensive stuff. Crank is the stuff that, the reason we cannot get a good decongestant over the counter without getting our driver's license. They've ruined it for all of us who have allergies and sinusitis, etc. Anyway. All right, antidepressants, SSRIs are okay. No Paxil though. Paxil is one of those that's linked to cardiac defects in the fetus. You can use Zoloft, you can use Prozac. We don't know of any long-term effects on the infant. Of course, we know on mom there are some, right? Anybody who takes Prozac, I'll leave this to your mental health course, but there are side effects, some that are, just untoward and some you really don't want. But here's the thing, there's a lot of research coming out on depression and fetuses and newborns over the past 10 or 15 years. Because in the past, it's like, if you're on an antidepressant, you were pregnant, get off it. Get off it right away. Well, now that's real smart to tell somebody who's depressed to get off of their antidepressant. It's like telling somebody who has high blood pressure to stop taking their antihypertensives, right? So what the studies are showing is it's more dangerous for a fetus to be in an environment, i.e. the mother's body, where she is clinically depressed than it is to take antidepressants. The reason is, I'm assuming you talk about this in mental health, but mental health is not just in your head. It has physiologic effects on your body, yeah? One important one, and it causes you to release a lot of an extra hormone. You know which one? Cortisol. The fight or flight, right? A lot of cortisol going on in there, and that's dangerous for a fetus. And it's dangerous for us too, right? It can cause a lot of problems down the line. So they're saying, if you're going to kill yourself, that's not going to keep your fetus healthy, is it? So there are some meds, as it says here, that may be better than others, but still, just yanking people off of their antidepressants when they get pregnant, whether it be planned or unplanned, is probably not the smartest thing to do. And I would suggest to you, if this happens to you or someone you know, because I know somebody that this happened to, a student of mine a few years ago, she was depressed and could not get her OB to prescribe her any medication. And it was taking forever to get an appointment with a shrink. But she couldn't go to a psychologist, she had to get a shrink to get a drug. And you know, they're booked out 3 months. And she's like, in 3 months I'll be dead. Somebody's got to give me an antidepressant. Finally went to the emergency room and they helped her. Seriously. Now, of course, you know it doesn't have to work right away. That took a little bit of her anxiety away, though, that she was going to kill herself. So there are still doctors out there, and this was just like 2 years ago now, because she's pregnant again. So about 2 years ago. And there's no reason for that. So I was telling you, if you get that kind of response, then go someplace else, ask somebody else, because that's not always the correct response. So opioids, of course opioids, of course. We got all kinds of opioids going around, don't we? Pill heads. One of my son's high school friends, he just told me the other night when he came over, OD'd last week. No, it didn't die though. And now he has seen the light. He says he's coming out of it. This is a kid who grew up with everything. So don't just think it's those kids in the hood taking opioids. It's all of them. If you get them, you're taking them. Seriously. So, growth restriction in the fetus, it is. It is. They call them, what do they call them? Blues? I think is I don't know, you all tell me, but I think that's it. Blues, I think that's what you think about. I don't know, I have an idea what color they were. Never had surgery, I don't have pain. That's not, I don't have pain. Okay. So, here's what A1 thinks about pregnant women with substance use disorders. It's an illness. Treatment can be cost effective. We're seeing a lot more treatment for opioid addicts during pregnancy because we're getting into methadone treatments. DACO over on, is that 50th Street or something like that? Somewhere over there. Does a wonderful job with pregnant women and getting them off of their street drugs and putting them on methadone. Now you say, well, that's just one drug for another. Well, okay, but maybe it'll keep them from prostituting themselves. Because, you know, if you're really drug addicted, you can't, like, get up and go to work or, you know, do a good job. You know, come home and cook dinner and do all that. So you got to do something that makes money, you know, on the side. So you're going to, you'll know this is true, okay? So at least it'll get them off the street drugs and get them off the street. And then help them to deal with their addiction later on. It is not unsafe for a fetus. What is unsafe for a fetus, so says a doctor from DACO that I saw at a conference about 2 years ago, is telling a mother on opioids, get off them, stop right now today. Because fetus is likely to suffer a seizure and die in utero. So we need to taper them off, and if it's methadone, that's fine. What you'll see in the NICU is methadone takes a long time, has a long half-life. Right? Because you can take one pill a day and it keeps you like this all day. Where some other pills, like, you know, any narcotic pill you might take, lasts how long? 4 to 6 hours, right? So methadone has a long half-life. So it takes a long time for these kids to get off methadone, but they do, and hopefully their parent will get off of it at the same time. But we support screening, A1 supports screening during the interview and throughout. We oppose laws that incarcerate. And in fact, right now, at least in the state of Florida, you cannot incarcerate a woman because she's pregnant just for using substances of any kind, whether they be illicit or not. You cannot do that. Now, if she's breaking the law, certainly you can do that and put her in jail, and she's not going to be using that anymore, I guess, if you believe the jails are clean anyway. So, but you can't say what you're doing is going to cause your baby to have 3 heads and, you know, 1 leg or no legs or whatever. You got to quit or we're going to put you in jail. You can't do that. But that doesn't mean you can't flag their chart. And when we flag their charts, we also alert surrounding counties. DCF does, because they might be smart enough to go and deliver in Polk County, thinking nobody will know and take their baby afterwards. Because even if you think they're crazy, they're still like the people on the Springer show. They want their babies. It's their baby by golly, and they're taking it home, and you're not getting it. And they think you're going to take their baby. And in fact, we might be. But the majority of the time, we don't. Interestingly enough. So here is our substance use care plan. Assess all women. Now, the thing is, you can assess all women, and how would we do that? Are we going to get a UDS or a urine drug screen on all of them? No, and the reason you don't is because it's a screening and it can be wrong. And once you get a positive drug screen, you have invited some really interesting people into your house and your life. And I guarantee you, some of you are doing stuff in your house that DCF is going to say is abnormal for your kids. William, don't answer this question. Do you have a female child? Answer this. You have a female child? Who has a female child? Jonathan, you have a female child. Don't answer this part of the question. Does she sleep with you in your bed ever? Okay, boom. That was bad. He did not answer that question. For the record, you cannot see him, because I told him not to. But if you did, I'm telling you, if somebody came in, they said, well, where does she sleep? Well, she sleeps in her own bed, but she wakes up in the middle of the night, especially on Saturday or Sunday morning. We bring her in, tuck her right in here in between us. They're like, not in your bed. No boys in your bed. I mean, I'm just saying, you don't want to bring these people down on you because they got some kind of microscopic eyeballs, okay? Okay, so we observe for the behaviors of substance use. Obviously, not showing up for your appointments, looking high when they come, smelling like weed. Do you ever see that in the hospital? Yes. Oh my goodness, even on the OB floor, I am not kidding you, you go into a patient's room and you're like, and don't tell me, because it don't smell like it did in the 70s, okay, but I still know what it smells like. And you're like, and it's probably not they've been smoking it, but it's on their body, in their breath. I mean, they're still doing it. Now, even if it's mom who tests positive for marijuana, guess where that baby's going? Even if the baby tests positive, guess where it's going? Home. Home. They'll look at the home. It's got to be really bad to not send a baby home because there's no place else to send them that's safer. Now, if they go to the home and they live in a box or, you know, everybody there's high, you know. But if there's some functioning people, they'll leave the baby. Which seems crazy, but they're here. What do I want to say? Okay, so one of our big jobs is to refer, but also to, what did I say here? Okay. What I really want you to know is one of our jobs is to, oh, it's on the neonate side, never mind. So for mom, here, you try not to judge her, okay? Because you don't know where she's been, what she's doing. And as soon as you start doing this, she's going out and she's not coming back. At least she's not coming back the days you're there, okay? It's really easy for us to say, well, everybody knows you don't take the crank when you're pregnant. But you know what? Sometimes they actually did look into this. They did a little study of their friends in their neighborhood. They have in research what we call a small N, meaning they didn't have 300,000 people contributing data. They had maybe 2 or 3. All those friends had babies, and they all used crank when they had them, and they all came out, their babies are fine. So they think, my baby's fine. It's just their study is flawed. It's not big enough. It's not broad. So the reason I say that is we must not assume that they think it's all bad. We have to gently ask in private and gently discuss and educate and refer. And the other thing you have to do is when you're giving them their pain meds, is you have to realize it might take enough to knock them out. Or you might have to give all you've got. And then they're still like, new pain medicine, it's not working. And so you're thinking to yourself, good Lord, it's enough to knock a horse out. But is that where we leave it? I've given you everything on your more, I can't give you any more. That's it. We're done.
You call the doctor.
You have to call the healthcare provider and report that what they're ordering and document that. Because otherwise you torture the patient, the doctor or whoever will say, well, I didn't know it wasn't working. Amelia never told me that. You're going to be, you just hate that you're in my eyesight.
That's okay.
So anyway, so you have to, they're very difficult. I don't know if you've dealt with them before, but if they are addicts, you're probably learning in mental health. What are they? Ooh, sick, but they're also manipulative. And they will try to wrap you around. They're very manipulative to get what they want. You have to, if you're going to work in mental health, my office mate Patrick always said you have to be very secure in setting boundaries and very clear about what the boundaries are, and don't get into their emotional life with them. That's not your job as a mental health practitioner. You have to help them move forward and follow the rules, basically, which they don't want to do. Okay, neonatal abstinence syndrome. I think we'll skip that. This is an acronym that, I don't think it's in your book, I got it at a conference a few years ago at TF General, called withdrawal, and it should be in your notes. Is it what it stands for in there? No, that's really interesting. If you ask me, I'll send it to you. And you don't have to write it down. So what do we do for babies who are substance addicted or withdrawing? Sometimes we do nothing except, I'm going to change it, do not have a heart attack. Except we do score them on the don't do it, don't have a meltdown. We do keep a score sheet, and we keep score of all of these symptoms. And the healthcare provider will write a parameter of, if they have a neonatal abstinence score of X to X, then do this, and it might be nothing, or do this, or do this, okay? And the things we're looking at, do they have a high-pitched cry? Like, ah, ah, instead of, wah, wah. You know, it's a cry, it doesn't sound right. You'll know it when you hear it. If they only sleep less than an hour after they eat, they get a 3, but if they sleep 3 hours after they eat, they only get a 1. And so it adds up like the sneezing's on here, loose stools, sweating, vomiting, and you get the total score, and then you go to your score that's been given to you by the healthcare provider, and you decide what you're going to give them. But let me say, a lot of times you're not going to give them anything. These are the options you can give them. Methadone, pretty much we only give to babies that are withdrawing from methadone. Okay? Phenobarb, oral morphine, tincture of opium, perhaps. I used to work with a doctor up in Massachusetts, a pediatrician. He gave a prescription of tincture of opium to all of his brand new patients when they came in, all newborn parents. And he would tell them, if in the middle of the night your baby's crying, screaming, whatever, and you think they're having pain, like they have an earache or something, go ahead and give them some of this. And then, you know, give it a little time to work. And if that doesn't work, go ahead and take some yourself, and then call me in the morning. Seriously. What do you think of that? What do you think when a pediatrician said that today in 2017? Well, they would never, right? Never. But this is a long time ago when healthcare providers, especially physicians, were a little more hoity-toity. But anyway, you can write all this down, but look, they're wakeful, they're irritable, they have, T stands for a lot of things, hyperactive, diarrhea, skin care, big, big deal for these babies. And I think, we're talking about skin care in your baby. I don't remember. But anyway, skin care is big because diarrhea is caustic. And only one diarrhea stool it can take to make them red, and the next one it can, you know, break their skin. Because they're having poor feeding is very, very big. So poor feeding and diarrhea, they usually have weight loss. And if you didn't get it all, don't worry. So here's our little care plan for these babies, what we're going to do. This is a urine collection bag. So it's kind of like a stoma bag. So we put that over the genitalia and then collect the urine in there for the urine drug screen. Our biggest job here is making sure that we've identified it correctly. Can you imagine not writing the right name on it or something? Or, you know, you've been calling this person 206 all day, and then somebody says to you something about Mrs. Jones, and then Mrs. Jones really 216. You write the wrong name down. Oh, Lord, you know, I mean, that's bad. Either way, it's bad. So, having chain of custody is what that's called. They have chain of custody. I label your, we should do this on all of our specimens, but in this case, we're really important. Label your specimens at the bedside and all the way through. These kids are irritable, so, and they have weight loss, so again, we feed them 24 calories. These kids feed like, they don't always suck really well, so you'll put a nipple in their mouth, and what you really see is like the formula drips out of the side of their mouth, kind of like a preemie does, because they can kind of gnaw on it, like, but they don't have coordinated suck-swallow, so they might, you know, chew, suck one, suck 2 or 3 more times, maybe swallow, but it's too much to swallow all at once, so some comes out. They don't suck swallow well, and so they get diarrhea and they have all these things. We can leave them cluster, swaddle, quiet, calm, non-nutritive sucking, even in baby-friendly hospitals like Tampa General. These babies get non-nutritive sucking, i.e. pacifiers. Okay. Breastfeeding only if they're not going to be using those substances anymore. Sometimes these kids need calm, quiet, etc. But I will tell you, I was in a NICU one time with students, and this baby did not like that. This baby liked to be out of everything. She was the cutest little thing. And she liked to sit in your lap facing forward. Now the nurses had already figured this out. So she didn't want to be up here. She didn't want to be over here. She wanted to sit in your lap. She looked kind of like Yoda sitting in your lap. Kind of hold her under her arms. Of course her head's kind of like this. But she wants to look out and see everything. And at that time she was still pretty old. Probably 5 or 6 weeks old. But still a little teeny thing. But that's what she liked as she was withdrawing from her drugs, which I don't even remember what it was. So even though it says do all that, sometimes it's not do all that. It's whatever works for this kid. Let me just say this. These children are very, and we'll watch that another time, but they're very at risk for neglect and abuse. Hold on just one second. And because they, you know how when you have a baby and they cry and you change their diaper and you feed them, then what do?
Keep crying.
And you rock them and they go to sleep. And they go to sleep. And you're like, oh, good mom, good dad, they like me. I got this down. I'm good at this. These babies, they don't do that. You can do everything. And they just keep screaming. Now put that in the home of someone who's marginally functioning. Okay? Kids screaming all the time. You know, very high risk for being abused and neglected. Because they can't take it. I often have told people holding these babies, like holding my grandbaby yesterday, you know, I'm getting all snuggled in my chest and stuff, and he's all soft, and I'm all soft and wrappy. These babies, it's like holding a 2x4. Because that's how they're laying there, like, it's not fun. It doesn't feel good. There's no reciprocation of goodness going on there. So parents don't attach to their babies. Babies can attach, but, you know, the parents are not attaching. Questions?
There was a slide with missing maternal associations with substance.
Oh, I don't know, maybe I took that out. I think I took it out.
Oh, okay.
I think maybe it was covered kind of, sort of. Oh, maybe I didn't.